Bismillahirrahmanirrahim. My name is Dr. Aamna Khalid. I am PGR Community Medicine. Today I will be presenting the topic of fat-soluble vitamins under the kind supervision of Professor Dr. Saira Afzal, who is Dean Institute of Public Health, Lahore. As I said, the fat-soluble vitamins is the topic. So the learning objectives will be we will go through the detail of each of them. So vitamins are organic micronutrients. They are required in small amounts. They are essential for growth, immunity, and metabolism. The fat-soluble vitamins will include vitamin A, D, E, and K. These are basically stored in liver and adipose tissue. Their deficiency and toxicity both are possible. So this is how we classify vitamins into the two categories: water soluble and the fat soluble vitamins. Water soluble include B complex and vitamin C, and the fat soluble vitamins include vitamin A, D, E, and K. These are some general features of fat soluble vitamins: that they are absorbed with the dietary fat. They require bile salts stored in body tissues, and the deficiency develops slowly. Risk of hypervitaminosis is there, and important in malabsorption states. First of all, we will go through the detail of vitamin A. So vitamin A is also called retinol. It exists in different forms, including retinol, retinal, retinoic acid. The vitamin received from animal source is the preformed, and from the plant source is provitamin. These are the sources of vitamin A. It can be categorized into the animal sources and the plant sources. The animal sources include liver, egg yolk, milk, butter, and the plant sources, the form is called beta carotene, and these we can get from carrots, spinach, mango, and papaya. Um, I'm sorry, it got stuck. I'm trying to. Okay. Functions of vitamin A. These include vision, dark adaptation, epithelial integrity, immune function, growth and development, and reproduction. The deficiency of vitamin A involve different organs, including eye, leading to the ocular diseases, infectious diseases, recurrent respiratory tract infections, diarrheal diseases, measles, skin and epithelial disorders, nutritional and growth disorders, reproductive disorders, hematological disorders, increased childhood mortality. So the ocular signs can be classified called xerophthalmia. This is classified according to the classification of WHO as XN, and that's night blindness. X1A, that's conjunctival xerosis. X1B, Bitot spots. X2, corneal xerosis. X3A or X3B, keratomalacia. XS, corneal scarring, and XF, xerophthalmic fundus. So this is again the symptoms. The ocular symptoms will include night blindness, xerophthalmia, bite or spot, and keratomalacia. And the systemic symptoms include dry skin, recurrent infections, and growth retardation. So the diagnosis of vitamin A deficiency um, based on history that will include poor dietary intake, lack of animal foods, recurrent infections like measles, diarrhea, malnutrition, poor socioeconomic status. Then we can do a physical examination, including the eye examination, dry, rough skin, signs of protein energy malnutrition, and growth retardation in children. Then we come to the laboratory diagnosis. The serum retinol is done, and if the level is less than 20 microgram per deciliter, then we label it as the deficiency of vitamin A. And if it's even less than 10 microgram per deciliter, then we label it severe deficiency. So this is a WHO high-dose vitamin A therapy in case of deficiency. If the child is less than 6 months, the dose will be 50,000 international units, and it's given on the day 1, 2, and 14. For 6 to 11 months children, the dose is double, that is 1 lakh international unit, and the schedule is same. Then, if the child is 12 to 59 months, then the dose is doubled from the second one, that is 2 lakh international unit, and the schedule remains same, that is day 1, 2, and 14. This vitamin A therapy is given orally, and it's life-saving in keratomalaysia. Ocular care has to be done, including the lubrication of the eye with eye drops, topical antibiotics if infection occurs, eye patching if corneal involvement has occurred, and urgent referral for corneal ulcers. How to prevent the deficiency of vitamin? The primary level is nutrition education, promotion of breastfeeding, dietary diversification, that is vitamin A rich foods, food fortification. Vitamin A can be added in the foods like oil, sugar, milks. Vitamin A supplementation programs can be carried out. Then the secondary prevention involves early detection of night blindness, screening of under 5 children, community-based surveillance, and early treatment of deficiency. Tertiary prevention involves treatment of xerophthalmia, management of keratomalacia, prevention of blindness, rehabilitation of visually impaired children. So now we come to the global burden of this disease. The estimated around 2.5 to 5 lakh children that are vitamin deficient, and they become blind every year. Half of them die within 12 months of losing their sight. And deficiency of vitamin A is associated with significant morbidity and mortality from common childhood infections, and it's the world's leading preventable cause of childhood blindness. Vitamin A deficiency also contributes to the maternal mortality and other poor outcomes of pregnancy and lactation as well. These are the cutoff values for public health significance as labeled by the WHO. The first indicator is serum or plasma retinol. That if in school age, preschool age children, if the level is less than 0.7 a micromole per liter, if the prevalence of this level is less than 2%, then it's not a public health problem. If the prevalence is 2 to 9%, it's a mild problem. 10 to 19%, moderate public health problem. And if the prevalence of less than this level, 0.7, then the problem will be severe. If it's more than 20, the problem will be severe. Then the second indicator is night blindness. In pregnant women, if the prevalence is 5 or more than this, then it's a moderate public health problem. This is the percentage of children aged 6 to 59 months who received 2 high-dose vitamin A supplements in 2023. And you can see that Pakistan is 90%. 90% of our children receive the 2 doses. This is the percentage of children again who received 2 doses in 2023, and the distribution is according to the areas, regions, and in South Asia, 83.1% were given the 2 doses. Now we come to vitamin D, which is also called calciferol, and it has two forms, D2 ergocalciferol and D3 cholecalciferol. It's synthesized in skin by sunlight. So the sources mainly sunlight, and in diet we can get vitamin D from fish liver oil, egg yolk, fortified milk. Functions of vitamin D include calcium absorption, bone mineralization, teeth development, muscle strength, and immunomodulation. Deficiency of vitamin D can cause rickets in children, osteomalacia in adults, bone pains, and general muscle weakness. These are the risk groups, including infants, elderly, pregnant women, and people with limited sun exposure. So high prevalence of deficiency, urbanization, indoor lifestyle, and cultural clothing practices are important as a public health aspect of vitamin D. So in children, rickets can occur that includes the symptoms of frontal bossing, rachitic rosary, bow legs, and delayed dentition. And adults can have osteomalacia that includes the symptoms of bone pain, muscle weakness, and fractures. Diagnosis is based on the low serum vitamin D level, 25 vitamin D, low phosphate levels, raised ALP, alkaline phosphatase, and X-ray metaphysical changes. So prophylactically, the prevention dose of vitamin D for infants is 400 international unit per day till 12 months of age, and in children, adolescents, adults, and pregnant and lactating women, the dose is 600 international units per day. The therapeutic dose means once the vitamin D deficiency has occurred, in children with rickets, the dose is 2000 international units per day orally for 6 to 8 weeks, or it's 50,000 international units once weekly for 6 weeks. Again, the adults with osteomalacia, the dose is 50,000 international units once weekly for 6 to 8 weeks, or it can be given daily, and the dose will be 6,000 international units for 8 weeks. Then after the treatment, maintenance dose will be 600 to 1000 for children and 800 to 1000 for adults in international units. And calcium supplementation should be done along with the vitamin D therapy. In children, 500 to 800 milligram per day, and in adults, 1000 to 1200 milligram per day. Calcium should be given. So this is the global and regional prevalence of vitamin D deficiency in our population-based studies from 2000 to 2022. This is a pooled analysis of 7.9 million participants. And you can see that 15.7% people had the level of less than 30, and 47.9% people were deficient with the level less than 50, and 76% people were deficient with the level less than 75. So deficiency, although has decreased in the last 10 years, but it's still high, and it's more in the high latitude areas, and it's more in the winter or spring season, and in the low income countries as well. And females are more vulnerable to vitamin D deficiency. So applying the three levels of prevention to vitamin D deficiency, the primary level includes adequate sunlight exposure, dietary diversification with the vitamin D rich foods, food fortification. Food can be fortified like milk and oil. Routine vitamin D supplementation in high risk groups. Secondary prevention involves early detection of deficiency, screening of high risk groups, early diagnosis of rickets and osteomalacia, and biochemical assessment. Tertiary prevention involves treatment of rickets and osteomalacia, vitamin D in calcium therapy, prevention of deformities and fractures, rehabilitation and orthopedic management. Public health and WHO recommendations are these are the same as repetition, so I'm skipping this slide. All right, now we come to the detail of vitamin E. This is also called tocopherol. This is a major antioxidant vitamin. The sources of vitamin E includes vegetable oils, nuts and seeds, green leafy vegetables, wheat germ. Functions of vitamin E are majorly antioxidant. It protects cell membranes, immune function support, and it prevents oxidative damage. Deficiency of vitamin A involve the neuromuscular, which includes peripheral neuropathy, ataxia, muscle weakness. Hematological involvement will be hemolytic anemia, especially in the preterm infants. So, retinopathy, although it's rare. High risk groups are premature infants, and those with chronic liver disease, and those with fat malabsorption syndromes. So we have to give oral supplementation of vitamin E in case of deficiency. Dose will be 2 to 5 milligram per kg per day in children, and it will be 100 to 400 international units per day in adults. And we also have to treat the underlying cause in the fat malabsorption, prematurity, liver diseases. We have to monitor for the clinical improvement if the involvement was neuromuscular or hemolysis, and optional serum alpha tocopherol, we can go for it. So again, applying the three levels of prevention. The primary prevention involves dietary diversification with vegetable oils, nuts and seeds, promotion of balanced diet with adequate fat intake, prevention and control of fat malabsorption disorders, nutrition education. Secondary prevention Early identification of the high-risk groups, screening in premature mature infants, detection of early neuromuscular or hematological signs, laboratory assessment with low serum alpha-tocopherol. Tertiary prevention includes vitamin E supplementation, treatment of hemolytic anemia and neuropathy, management of underlying malabsorption disorders, rehabilitation of neuromuscular complications. So now we come to the detail of vitamin K, which is also called phylloquinone. This is essential for blood clotting. These are the sources of vitamin K, which include green leafy vegetables, intestinal bacterial synthesis, broccoli, and cabbage. Uh, Functions of vitamin K are synthesis of clotting factors, growth hormone formation, and bone health. Deficiency of vitamin K can cause bleeding disorders, prolonged clotting time, hemorrhagic disease of newborn. So the hemorrhagic disease of newborn um, is due to sterile cut, low placental transfer of vitamin K, and low vitamin K in breast milk as well. So it is classified into the three types. The early disease is when it occurs in the first 24 hours. It's classical when it occurs from 2 to 7 days, and it's a late occurrence of the disease when it's from 2 to 12 weeks. It's diagnosed clinically um, and on the basis of some laboratory test, which includes prolonged PTINR, normal platelet count, and normal bleeding time. So we have to manage the newborn with giving the prophylaxis of 1 milligram of vitamin K intramuscularly at birth, which prevents hemorrhagic disease. We have to monitor it later on with PTINR after administration, and the therapeutic bleeding dose is 1 to 2 milligram, which is given IM or IV. So the primary prevention includes K prophylaxis at birth, adequate maternal nutrition during pregnancy, promotion of balanced diet, and prevention of prolonged antibiotic use. Secondary prevention includes early detection of bleeding tendencies, screening of the high-risk newborns, monitoring with PTINR in the suspected cases, and early diagnosis of vitamin K deficiency bleeding. Tertiary prevention includes treatment with vitamin K injection, management of the active bleeding, use of blood products if required, and prevention of complications like intracranial hemorrhage, etc. So this is again the same thing. So now we will discuss the toxicity symptoms. That if there is excess of a specific vitamin, what will be the symptoms? In case of vitamin D, abdominal cramps, nausea, vomiting, calcium crystal deposits that can affect liver, kidney, lungs. Calcium salts are irreversible. Excess of vitamin A can cause accumulation of fluids in the brain, vomiting, tiredness, constipation, bone pains, brittle nails, hair loss, birth defects. Then the excess of vitamin E can cause headaches, tiredness, double vision, diarrhea, vitamin A, D, K deficiency, like deficiency of further different vitamins. So this is an article published in 2025. uh, Potential of fat soluble vitamins as a platform for antiviral drug development. So the soluble vitamins, including vitamin A, D, E, and K, they exhibit antioxidative, anti-inflammatory, and immunomodulatory effects. So all of these qualities make them promising candidates for antiviral drug development. And this review highlights their structural features, biological roles, and antiviral potential. Vitamin A derivatives modulate immunity and inhibit viral replication, including SARS-CoV-2. Vitamin D analogs enhance immune responses and target viral enzymes, while vitamin E derivatives reduce oxidative stress and may directly inhibit viral replication. So, the emerging research on vitamin K derivatives suggests potential antiviral applications. These findings underscore the potential of fat soluble vitamins as innovative antiviral agents, warranting further investigation to optimize efficacy and clinical use. So now we come to the practice of MCQs. Question number 1 is, a malnourished child presents with corneal softening and risk of perforation. The most appropriate immediate management is option A, Oral multivitamins. Option B, topical antibiotics. Option C, high dose vitamin A therapy. Option D, steroid eye drops. And option E, antiviral therapy.
C.
C.
Y- Yes, option C is the right answer. Question number two. A 55-year-old woman presents with diffuse bone pain and muscle weakness. X-ray shows pseudo fractures. Most likely diagnosis is option A, deficiency of vitamin A, or D, or E, or K, or vitamin B.
D.
B. Beta.
Yes, deficiency of vitamin D. Question number three. A patient with chronic fat malabsorption presents with ataxia and peripheral neuropathy. The most likely deficient vitamin is option A, vitamin A, or B, D, or E, or K.
A.
It's vitamin E. C is the right answer. As ataxia, peripheral neuropathy, these are the neuromuscular symptoms of deficiency of vitamin K. E. So now we come to question number four. A newborn develops bleeding from the umbilical stump on day 3 of life. PT is prolonged, platelet count is normal. So the diagnosis is option A, hemophilia, option B, thrombocytopenia, option C, vitamin K deficiency bleeding, option D, DIC, option E, von Willebrand disease.
C.
C.
Charlie.
Yes, C is the right answer. Question number five. A patient on prolonged broad spectrum antibiotics present with easy bruising and prolonged PT. The deficiency is due to loss of option A, dietary intake of vitamin A, B, sunlight exposure, C, intestinal bacterial synthesis of vitamin K, and D, liver storage of vitamin D.
Charlie.
Yes, Charlie is the right answer. Question number six. A 3-year-old child from a low-income household presents with inability to see in dim light. Examination shows conjunctival cirrhosis at bite or spot. And the most appropriate immediate intervention is dietary counseling should alone. Um, Option B, topical vitamin A eye drops. C, oral iron supplementation. D, high dose oral vitamin A as per WHO schedule. Option E, parenteral multivitamin injection.
D.
D.
Yes, D is the right answer. Question number seven. A 2-year-old child presents with bowing up legs, delayed lower of fontanelle, and rachitic rosary. Laboratory findings show low serum phosphate and raised alkaline phosphatase. The best confirmatory test is option A, serum calcium, option B, serum parathyroid hormone, option C, X-ray of wrist, option D, serum 25 hydroxy vitamin D, option E, serum calcitonin.
D.
C.
Yes, D is the right answer as we are suspecting deficiency of vitamin D. Question number eight. A 45-year-old woman with osteomalacia is diagnosed with vitamin D deficiency. Which of the following is the most appropriate therapeutic regime? Option A, 800 international unit daily for life. Option B, 400 international unit daily for 6 weeks. Option C, 50,000 international unit vitamin D weekly for 6 to 8 weeks. And option D, single IM injection of vitamin D only. Option E, calcium supplementation alone.
C.
Yes, option C is the right answer. In adults, 50,000 international units weekly. Question number 9. A premature neonate develops anemia with fragmented red cells and muscle weakness. Which of the following patients is at highest risk of developing vitamin E deficiency? Option A, healthy adult on vegetarian diet. Option B, uh, option B, elderly person with osteoporosis. Option C, child with chronic cholestatic liver disease. Option D, pregnant woman with anemia. Option E, neonate receiving vitamin K at birth.
E.
A.
D.
C is the right answer. As we discussed the risk factors of vitamin E deficiency, so we studied the cholestatic liver disease in that slide. Question number 10. A child with cystic fibrosis presents with night blindness and prolonged prothrombin time. Which combination of vitamin deficiencies best explains this presentation? Option A, deficiency of vitamin A and D. B, vitamin D and E. Third option is vitamin A and K. Fourth option is vitamin E and K. And fifth option is vitamin A and E.
E.
C.
Charlie. C.
Yes, Charlie is the right answer. This is the answer key. This is a YouTube channel of Institute of Public Health Lahore where this presentation will be uploaded later on. Thank you.
Thank you so much. It was a very good presentation.
Thank you, Dr. Amna.